So thank you again for the Sepsis Alliance for inviting me as a representation from Ceylon College of Physicians. I would like to introduce sepsis, the continuum, to this audience. And I think we already heard about sepsis, the burden of it. So it affects about 45 million people in the world, with about 11 million succumbing to sepsis. So it's a leading cause, especially of mortality, especially in the ICUs. And what we really have to understand is that it's a continuous process, which is initiated initially by the infection and which evolves into a more of a systemic clinical syndrome. So the definitions of sepsis have again evolved over time, and with certain terms such as severe sepsis going out of practice. So what I'm sticking to is the current definition, which is sepsis as a life-threatening organ dysfunction due to a dysregulated host response to infection. So when we look at this definition, you can see that there are two important components. One is that there is infection. And this infection, which could have been localized at onset, has now given rise to an organ dysfunction, which could be life-threatening. So let me introduce you to Mr. N, a 67-year-old patient. So this is kind of the patients that we encounter in wards every day. So he has come with fever, confusion, and shortness of breath for about 1 day, and complaining of reduced urine output. So he has diabetes, hypertension, and stage 2 CKD. So he was recently treated by his family practitioner for a possible urinary tract infection. But he has continued to have about some dysuria and low-grade fever despite antibiotics. So, and on admission to the ward, he's confused, disoriented, he's febrile and tachycardic with a pulse rate of 120, blood pressure 80/50, his respiratory rate is 26, and saturation is 92% on room air. So the question is this sepsis? So to say that patient has sepsis, we look at the two components that I discussed before. So infection, which could be a clinical suspicion most of the time with the history. When the patients present to us, clinical suspicion is what is most important. And in our patient with the given history, he has, of course, a very high degree of suspicion of having a urinary tract infection, probably even pyelonephritis. And then, of course, microbiological and other laboratory investigations, bedside tests will also help us to determine whether the patient has an infection. But unfortunately, most of the time, or sometimes, it's not very clear or apparent whether the patient has an infection, so especially in certain populations, such as elderly people. So they might not have overt clinical features, or their investigations might not be available. So retrospectively, we might actually diagnose infection when these patients respond to antimicrobials. Of course, then, if we think this patient has infection, then of course, we want to know whether there's organ dysfunction. Now, what organs should we look at and what sort of tools can we use? So unfortunately, again, here, there's a lot of controversy about what sort of tools that we can use bedside or in the ward. SOFA score, which is the Sequential Organ Failure Assessment Score, assess organ dysfunction, looking at several organs. And a score more than 2 tells us that patient has organ dysfunction. However, this has been validated for ICU settings. And the QSOFA, or the Quick SOFA score, which is more of a practical tool to be used in ward setup, is actually not reliable or sensitive enough to detect all these patients. So it's a combination that we might have to use, and things like NEWS, MEWS, or even search criteria might be important to identify patients to see whether there is organ dysfunction. So just showing you what organs that the SOFA score is looking at. So these are the organs that will get involved in a patient who develops sepsis. So respiratory, PF ratio, then the mean arterial pressure, or the requirement of vasopressors tells us that there's cardiovascular involvement. Bilirubins will tell us there's liver dysfunction. Elevated creatinine indicates, again, renal involvement, and platelets, the onset of coagulopathy. And more importantly, clinically, if the patient has low Glasgow Coma scale, of course, that indicates that patient might be having encephalopathy due to sepsis. So you see that it's not very easy to diagnose organ dysfunction or sepsis per se, because there is no one tool that will tell us that this is sepsis. And these features, some of these clinical features that I described can be very non-specific as well, can be there even without sepsis. And also there could be quite subtle features, and we might even underdiagnose. So which is why it's very important to keep in mind and have a high degree of suspicion, plus use appropriate assessment tools to see whether these patients have sepsis. So why do I say it's a continuum? Because the sepsis starts off initially with an infection. So in our case, in the patient that I described, a urinary tract infection, which from that local infection spreads into more of a systemic inflammation. So although the infection is confined to the kidney, it goes on to develop significant systemic features due to this immune response. So our patient had tachycardia, tachypnea, fever, and altered mentation. And of course, following this continuous inflammation, these patients develop organ injury. So there is septic shock, acute kidney injury, ARDS, disseminated intravascular coagulation or coagulopathy, all indicating, and as well as liver injury, and patient goes into multi-organ dysfunction syndrome. So if you look at this color spectrum, it might be very easy for you to identify red from yellow or even orange, but you see that there is a gray area where it all merges together. So it's very difficult to say where red actually starts. So in the same way, in a patient, it might be very difficult to pinpoint and say, this is where this patient is going into sepsis from the local infection or the systemic infection. So it's an evolving process, and identifying them early in the process is key. And that is why I think we are having this Congress talking more about it. So let me just briefly show you how the infection goes on to bacteremia, so more of a systemic infection, which leads to the inflammation or the sepsis. And finally, these patients are going into septic shock. And septic shock, as well as multi-organ dysfunction syndrome and death. So the infection that we described, for example, in our patient initially was the local infection, probably an infection in the kidneys, the pyelonephritis. So our immune response will, of course, mount immune response against these bugs to get rid of the infection. But this bug will also spread into the blood and cause a bacteremia. So this local infection that was just a pyelonephritis will be more of a bacteremia. And then this local inflammation that occurred as a defense mechanism now leads into more of a systemic inflammation. And the main culprit who drives or link this local inflammation to more of a systemic inflammation is actually the endothelium. So endothelium plays a significant role in the pathophysiology of sepsis. And we know that there's a lot of changes happening in the microcirculation, which is the reason for organ injury. So the endothelial, there is a dysfunction. Plus, endothelium actually secretes a lot of inflammatory mediators, chemoattractants, and many cytokines and other mediators. And this leads to the systemic inflammation. Apart from that, the damage or the endothelial dysfunction activates the coagulation cascade, and there's inhibition of fibrinolysis. With all this, there is microvascular thrombosis. So microvascular thrombosis, again, leads to organ hypoperfusion. And that can be detected when we do bedside tests such as lactate, where we see lactate going up. And of course, the hypotension that develops in these patients are also due to the significant vasodilatation as a part of this inflammatory process, so that they develop hypotension and requirement of vasopressors to maintain a blood pressure, or they do have high lactate. So we categorize these group of patients as septic shock. So it's not simply a reduction in the volume, but more of a vasodilatation and inflammatory response that gives rise to shock in this group. And of course, at the end, the end result is the multi-organ dysfunction syndrome, where patients might get acute kidney injury, adult respiratory distress syndrome. So our patient had hypoxia, tachypnea, could be developing ARDS. And there's definitely a reduced urine output in our patient. Probably there is AKI. And reduction in the mentation or CNS involvement, and then liver injury. And also these patients, because of the coagulation activation and the micro thrombosis that I discussed, these patients also develop a disseminated intravascular coagulation leading to bleeding and other complications as well. Therefore, what I've discussed here is more of a continuous clinical syndrome, which starts off initially by an infection. So there's a source of infection, which causes these bacteria to enter the bloodstream, causing a more systemic infection. And more than the infection or the bacteria per se, it's the immune response that is mounted, which is overwhelming, driven by the endothelial dysfunction that causes this significant systemic inflammation. And that manifests as hypoperfusion to many vital organs, causing organ dysfunction and leading to finally death. So as clinicians and doctors, what is very important for us is understanding this continuous process and trying to identify our patients when they present at any of these steps in this continuous process. So to wind up, I would like to say that sepsis is a cascade of inflammatory events due to an initial infection that triggers the whole process, which might be a simple local infection, but that is, if not treated in susceptible individuals, progresses into more systemic infection, and that leads to a systemic inflammation, causing organ hypoperfusion and dysfunction. And what is really important is early detection of sepsis to reduce mortality and to make sure that we do the best for our patients, which I think is going to be dealt in the future presentations. Thank you.